Hello, I'm Bruce,
And I'm Aditya.
and we are the Risky Scientists. So I teach risk management at the University of San Diego,
And I teach data science at Harvard.
and in these episodes we want to help you to understand risk. And this week we're going to look at COVID-19's unintended consequences. So let me put my political science hat on and first of all say that policy involves trade-offs, and this is one of the facts of life that politicians often want to hide from you. So they want to say, we got a policy, we got a solution here, and this is the best thing ever, and we're going to solve this problem. And they don't want to talk about the side effects. So let's use a medical term. Policies.
They're not thinking probabilistically then, right? They're thinking in terms of sureties.
Or to put it another way, they're thinking narrowly.
Yeah.
So they are. I mean, they're spinning their policy. They're saying, let's just focus on the positive here.
Yeah.
But policies always have negatives. It's like everything we do is a trade-off. So we can focus on this money-making opportunity, but that is taking away attention from other things we could be doing. So there are opportunity costs to everything we do, and policy is a bit like that. So we can focus on COVID-19, but we're going to take away attention from other health concerns or other, not even health concerns, but other public societal concerns. So I'd also say there are unadmitted consequences of how we are managing the COVID-19 emergency, and that's what we want to focus on in this episode. Right. So Aditya, you mentioned the British case. So the British case is particularly interesting because policy has changed a lot in Britain. So first of all, it was herd immunity. So the idea was pretty much, the message was to society, you go out and catch the disease, just don't catch it too quickly, because then you overwhelm the health service. Yeah. So sort of a perverse message, and quickly the government abandoned that message, although there's parts of the policy are still in practice in effect. And then the government has switched. I mean, the government switched policy so many times I've frankly lost count. But the main policy for the last few weeks has been protect the NHS. So this is the official message: is protect the NHS, flatten the curve, so that we can we don't want to overwhelm the NHS. Now, there are some of the unintended consequences of this that I want to highlight. Is that protect the NHS message has encouraged people to avoid the NHS even when they should be using it. Mm-hmm. This includes the NHS, to be clear, is a national health service, so it's a publicly funded but largely non-profit contract-based.
So what are some of the examples of people where they should be going to the NHS that maybe they're worried because of the policy?
Yeah, so unintended consequences. So we know now that people with serious non-COVID conditions, such as life-threatening cancers, cardiac problems, needs for kidney dialysis machines, they're not getting their normal routine treatments because they're voluntarily trying not to put demand on the NHS, or they're being told, you should defer or postpone the treatment. So there are people with current conditions who are not getting their normal treatment, and that is risky. And then there are also people who are not yet diagnosed, but they are deferring making a demand on the system. You know, I may have symptoms of cancer, or I may have been scheduled, I may be on a waiting list to get properly diagnosed, to have a diagnosis confirmed, and I cannot get that appointment because the NHS is not allocating capacity anymore to that. So there have been some estimates that at least thousands of people, in excess of a normal modal death rate for cancer. So thousands of people in the next year of time are going to die of cancer in Britain in excess of the modal lethality rate for cancer. So now we have to think about what is the death rate of COVID?
Yeah.
And then what are the excess deaths that have got nothing to do with COVID, except that they are consequences of how we are responding to COVID.
Mm-hmm.
And then we should mention too that there are COVID-19 patients
Yeah.
who are not seeking treatment because they're trying not to put demand on the NHS. And this is true. We've got evidence from this in New York City too,
Yeah.
where a similar message is, don't go to the hospital unless it's really an emergency.
Yeah.
And that means that people with COVID-19 may wait to the last minute when it's too late.
Yeah.
And there are some medical peculiarities about COVID-19, the way it manifests, that make this particularly dangerous, because COVID-19, it can damage the lungs through symptoms like hypoxia, which is a shortage of oxygen. People are struggling to breathe.
But the really dangerous thing, I think.
It's dangerous because the patient doesn't know how much damage they're doing to their lungs until there's a critical threshold reached when the lungs start to collapse.
Yeah.
And by that stage, it may be too late to save the patient.
Right.
So if people are voluntarily waiting to the last minute to make use of healthcare, it then perversely makes it more difficult for healthcare providers to then save the patient. So this is another unintended consequence within the risk of COVID-19 itself that you're trying to manage.
Yeah, I think that's very well said, and it feels like it's one of these very difficult cases because on the one side you want to prevent as many people from, I think now the policy mostly seems to be let's prevent people from catching it, and we should talk more about herd immunity later, right? But if you want to...
So to clarify, that's social distancing and that's staying at home, depending on what state you live in. Exactly. So to clarify, that's in risk management terms, that's about avoiding exposure. So if you never are exposed to an infected person, you have no risk in theory. Right.
Yeah.
So and in a way that's more efficient because that's sort of preventative. We don't have to treat your manifestation of the disease if you never catch the disease. So in most ways, we can think of that as an efficient response to the controlling the risk of the disease if you never catch the disease. However, an obvious trade-off is economic activity and social goods, social interaction and normal social activity.
And I think you're bringing up something else, which is not just the economic trade-offs, which I think we're hearing a lot about, especially here in the United States in conversation right now, but also of medical activity. And I mean, we're not medical doctors, but at the same time, I think from a statistical perspective, it's very clear that deaths are rising greatly because of COVID, and people are passing away because of COVID, but also other potential illnesses are also being exacerbated. So there's kind of two sides to this coin. On the other side, however, there is some sense behind trying to limit people's visits to the hospital because on the other side, you have risks that are perhaps so I think it's one of these cases where you have risks that are probably more dangerous. Again, not a medical doctor, but it does feel like for most people, stage 4 cancer or something like that is more risky than COVID. But then again, for most people, I think a little pimple is probably less risky than COVID. And you're hearing of many cases of people who are going to the hospital for some other issue, whether it's very dangerous or not, and then contracting COVID in the hospital. So it seems almost as though the problem is that there's a mixing and a melting pot, and we can talk about solutions in a moment and kind of from a risk management perspective. What would you do if you had these two parallel risks and these parallel tracks and you wanted to minimize them interacting with one another? Because
what you're talking about is it's an unintended consequence of risk that is actually avoidable.
Yeah.
So if you are saying to people, we're going to provide these special emergency hospitals. There's going to be a few emergency hospitals where we want to treat COVID-19. And if you have COVID-19, we're going to centralize all our response to that. So we're going to test you there. We're going to treat you there if necessary. If necessary, we're going to do everything in this central response. Okay, so that's going to be at least economically efficient for the healthcare system.
Yeah.
And it could be medically effective because now you're centralizing your expertise. So your healthcare providers, they're getting their experience in one place, and it's easier for them to communicate. So that you can imagine payoffs of effectiveness in healthcare if you centralize the system. Now, the downside of this in terms of risk is that you are now providing a centralized incubation and infection point for the virus.
Yeah.
So you may have patients showing up who are not even infected with COVID-19, but they have symptoms that for some reason they are worried, they have anxieties are COVID-19. So they show up to this central point of treatment, and then they are more likely to get infected by COVID-19 because of this environment. So that would be an unintended consequence of your efficient and effective centralization of healthcare for COVID-19, that you actually increase the infection rate. And this is a problem not just for COVID-19, but it's a problem with centralized health systems in general. So for instance, to go back to Britain has had various scandals of what are called superbugs, where hospitals incubate evolved versions of deadly infections, viruses and bacteria that patients catch in addition to the condition that they went into hospital in the first place. Obviously, you can control that new risk by hygiene, disinfection and so forth. But those measures are now difficult to control because staff are busy.
PPE is often lacking.
The accountability for cleanliness is quite difficult because it's difficult to verify what is clean. And particularly when hospitals are operating all the time. There's a routine aspect to that, but it's actually quite difficult to verify whether the routine process is actually producing cleanliness. So Britain had a shortage of personal protective equipment in its healthcare system. So this too is a consequence of previous policy. So if you're doing herd immunity, which was Britain's first approach, you don't need personal protective equipment. Big changes policy. Now it realizes that herd immunity isn't working. There's a shortage of personal protective equipment, which means healthcare staff are circulating amongst patients without personal protective equipment. They're getting infected. They're carrying the virus. And the problem we know happens in centralized healthcare provision, which is it's perversely easier to get exposed to pathogens in hospital than not. Now that risk is being exacerbated. It's not being controlled by personal protective equipment. Now Britain has a better supply of personal protective equipment, but because of the incubation period of the virus, there is a lag effect, and it's also an exponential. If you're allowing for exposure, eventually the infection rate is going to become exponential. So Britain, that's one of the explanations for why Britain is on track for being the most lethal, having the highest lethality rate for COVID-19 in Europe. So it's undercounted. It's undercounted too. And we should talk about unintended consequences of that, because British policy under herd immunity also said we don't need testing equipment like South Korea, Taiwan, and other countries invested in very quickly. Now, to be fair, Britain has then invested heavily in testing equipment. But in retrospect, the risks of these policies, in retrospect, are easy for us to describe.
Yeah, absolutely. I think you were saying unintended consequences and undercounting. I mean, I think we're seeing this everywhere globally. Nursing homes, elderly people living at home. You're not even finding these people who often have very severe cases or or fatal cases until much, much later.
Yeah, so that was literally true in the British case, because British government policy was do not visit care homes.
Yeah.
So the British government said to the families of the elderly who are resident in care homes,
Mm-hmm.
said to the families of those residents, don't go and visit them because you may carry the infection to them. So effectively the government saying, isolate the care homes, don't visit them. Now that sounds like a good idea in terms of exposure.
But if it's too late.
However, right, if the infection is already in the care homes,
Yeah.
now you're not providing health care, because part of the policy of not visiting the care homes is
Right.
you're not sending health care to the care homes. The care homes are don't normally have medical provision,
Yeah.
at least on a level like a hospital. So now you've got care homes that are isolated, but they're circulating the virus inside the care home.
Mm-hmm.
Even greater shortage of personal protective equipment inside care homes and hospitals, because what personal protective equipment was available was being prioritized for the hospitals.
Yeah.
So the circulation was by staff who were not wearing personal protective equipment.
Yeah.
If people were getting sick, they weren't getting medical care
Yeah.
beyond what was available inside the care home. So care homes turned out to be the riskiest places to be.
Yeah.
Which is perverse, because the policy, this is an unintended consequence. The policy was, let's protect care homes by isolation, but in fact that was turned out to be the worst thing to do if you're also going to deny the care homes health care and personal protective equipment.
Right. And I guess it also says something, though, about, I think you're making a point about kind of that you can view from a statistical perspective is the risks add up as you start adding more and more people to a social isolation bubble, let's say, right? And that's why I think we've seen some very scary examples, care homes perhaps the most scary, but also cruise ships, these large hospitals, all these places where basically you might be trying to wall off this bubble from the outside world, and that's good for everyone else, right, in terms of exposure, but that also means that inside of this bubble, you throw a lot of people and it becomes this really dangerous melting pot, I think.
So just to clarify, so cruise ships, as I understand it, there's an engineering perspective to the risk on cruise ships.
Yeah.
So what has been explained to me is that cruise ships, because the isolation policy was, let's not let the cruise ship into port if it has a case of COVID-19. So don't let it into port for 2 weeks, so that we can allow for the incubation period to play out, and then we know what all the cases are, and then we will let them into port. Or actually, and a more extreme policy is you must wait for 2 weeks without any cases, without any new cases, before we let you into port.
But I think the problem I've heard is that and I'm not a cruise ship engineer, but like you were saying, I've heard that the air passage is often the same across many rooms in cruise ships. So you're not really quarantining.
Right. So the policy was not to self-isolate on deck in the open air. It was to self-isolate in your room. And the ventilation is through a shared ventilation system with no filters. So if somebody is infected, they're breathing out into their room, and then that infection is then getting circulated into other rooms.
I mean, so it sounds to me like so far what we're saying, Bruce, and especially what you're saying, is there's two buckets that I think are starting to emerge from this conversation of unintended consequences. One in terms of measurement. So this is the silent hypoxia, right, where we don't even know that people. And that's I mean, if I have the virus, I don't even have insight into myself because I'm not realizing that I'm low on oxygen. And the government is not shipping oximeters to everybody. So that's perhaps something else we can talk about, right, is getting active in diagnosis. So there's one bucket of diagnoses and unintended consequences related to diagnosis. And the other is, of course, in terms of outcomes. So people, cancer patients and cardiac patients and dialysis patients maybe not receiving, or even elderly patients who just need maybe more close monitoring of their condition.
So in risk management terms, so the way I'd interpret what you say there is, I think the two buckets in risk management terms are preventative and responsive.
Yeah.
So ideally, as we talked about earlier, we want ideally our risk management is most efficient if it's preventative, because then if we prevent you getting exposed to COVID-19, we don't have to invest in the resources necessary to treat the disease, which is going to be very expensive and invasive, and it's going to even lockdown, even personal lockdown is costly. It's very costly to the economy, for instance, not just the economy but social life. So if we can prevent we can prevent exposure in the first place, we can avoid some of the costs of the responsive part of our risk management. Now the hypoxia part is a good illustration of this, and now we understand hypoxia, this silent hypoxia as it's called, so damage to the lungs because you're struggling to breathe, but perversely you actually don't know how much damage you're making until the lungs start to collapse. Now, the original policy concern was, do we have enough ventilators? But countries like Britain were appealing to private citizens to make ventilators to try to increase the stock. Now, doctors in New York, in particular, have pointed out what we need more than ventilators, which is a responsive part of our risk management. What we need are oximeters, which is the preventative part. Because if we can, oximeters allow the doctor to measure lung function, or how efficiently the lungs oxygenate the blood.
Right.
So that is a way of testing for silent hypoxia. So we can catch that lung damage early, and then we don't have to put people on ventilators, which is more towards the responsive end of the cycle of the disease.
I mean, if I, again, not a doctor, but normally if I understand it correctly, if you have low blood oxygen, you're going to start gasping for air. But something in the COVID mechanism is killing your own feedback system. So these people are very low, which normally means they should be gasping for air and they would have rushed to the hospital, but they don't even realize it. But I want to throw out for our listeners just one thing that's kind of come to mind recently, which is this notion of counterfactual thinking. And the reason I like this notion of counterfactual thinking lately is because it's a way of kind of wrapping up some of the unintended consequences in one little bucket. So I think for people who are saying, well, look, COVID is not really anything. I think globally, all around, we're seeing a spike in the total number of deaths, much beyond the averages that we would normally see for a given month. So normally, deaths do fluctuate depending on the season and the reason, and there's lots of things. I mean, flu is also often seasonal. But the counterfactual thinking basically says, let's imagine what the world would look like if we extrapolate. So this is regression for people who are interested in statistics and data science. So let's extrapolate from previous years what 2020 would look like. And then we go and look at the data and we say, well, look, no, 2020 isn't like what we thought it should look like if things were the same as previous years. And so it clearly shows you that some other things are going on. And it might be just an insight into starting to think about, well, what else is going on? So there's COVID, but are there other data sets? So are we seeing, for example, a spike, not just in COVID-related deaths, but in deaths related to other medical diseases, potentially because we're catching these things a little bit too late, perhaps because these other things are not treated. So my kind of takeaway from this is right now to be thinking counterfactually, to be thinking about what the normal would be, and then going to look at the data as a data scientist and saying, well, no, here's what the data is saying. And beyond COVID, what's also not normal. That is kind of a way for me to get my head around this. But from a risk management perspective, what are the solutions you recommend?
So for me, a lot of what you're talking about is best analyzed in terms of trade-offs. So we can, the most basic lesson here is that policymakers and then we as public consumers of policy, we need to be always mindful of the trade-offs. We need to be honest and admit whenever there's a policy, it doesn't matter what the policy is, there's always going to be trade-offs, right? If you spend money on this, you're not spending on that. That's a simple trade-off. With any policy, there's going to be trade-offs. So if we focus on COVID-19, for instance, you can predict there are going to be unintended negative consequences for other disease management.
Yeah.
So we need to be honest about trade-offs. There are always trade-offs in policy. And in terms of risk management, we can say, if we control this particular risk, what other risks are we not controlling now?
Yeah.
What's the impact, negative impact on our controls of other risks?
Right.
If we control this risk in this particular way, what negative aspects are we actually controlling? Meaning what negative aspects are we actually mitigating, bringing down their negative consequences?
Yeah.
But what negative parts of this risk are we not tackling by our policy measure? So, for instance, if we are prioritizing hospitals for personal protective equipment, let's be honest that the care homes are not going to get personal protective equipment. So the basic message here is awareness of trade-offs, awareness. And in terms of analysis, this is where a data scientist comes in. Let's put numbers on these trade-offs so that we can then make more accurate policy decisions about, maybe controlling this risk in this way is not worth the negative trade-offs in this other area.
Yeah. I think that's very well said. It comes back to putting our cards on the table. We probably will always have to eat one or two unappealing cards. And I think it's important to state what those are, though, because clearly I think we all have opinions on what's more important than others. But we have to kind of group these perspectives, right? So if you're in a care home, you have a very different perspective than somebody who's maybe on the medical front lines or somebody who's 17 and in high school.
And we've mentioned this before. There are explanations why Britain's policy has been unstable. They have a scientific advisory group for emergencies, SAGE, which contains scientists who are not, they're anonymous. So there's a lack of accountability. So we've talked in our episodes on scientific process, accountability and transparency are very important. That improves science. When those things go away, you often get bad science, or at least an inattention to good science. Let's put it like that. And we know now that there's something we've learned from the news that we were not aware of when we last talked about this scientific advisory group. Now we know that they're actually not independent scientists. So that most of them are not independent scientists. Most of them work for the government. So now they're not even, now the accountability problem is they're not accountable through transparency. Now they have a stake in government policy. So they because they're part of the government, they have to be defensive. They don't have to be, but they have an interest in being defensive of government policy. So now we have a majority of the people on the supposedly independent scientific advisory group who are actually working for the government that they're supposed to be independently advising.
I mean, maybe we should think about what are your takeaways from this? I mean, what advice would you give yourself or give to our listeners based on what we know about the fact that there will be unintended consequences no matter what happens?
Yeah, well, as I said, there's the awareness, the honesty about unintended consequences and trade-offs in general. If you're honest and aware that those things actually exist, they're inevitable with policy, it encourages you to go looking for them. I think from a risk management perspective, like we said, we're not medical doctors. From a risk management perspective, there are some structural solutions to the problems that we've talked about, particular to COVID-19. We talked about centralized healthcare. There is a recommendation here for segregating your healthcare. So that you can have various echelons of healthcare where you direct people that you test and confirm have COVID-19, you direct them into a segregated part of your health system where only diagnosed patients with COVID-19 are treated. and that helps you to avoid exposing people who need healthcare but are not yet infected with COVID-19.
Yeah.
So segregation. So that's an alternative to a centralized medical system where everything is delivered, all treatments are delivered at one point.
So you're talking about preventing exposure, I think.
Yeah.
And,
yeah.
Maybe the big thing that comes to mind for me is better diagnostics. So, I mean, can we do better with telehealth? Can we do better with at-home diagnostic capabilities for a variety of illnesses, maybe? And that includes COVID, right? So I think a lot of people are coming up with at-home COVID testing. It still seems like it's not quite perfectly robust, but it is, I think it's getting better, it seems like. But that feels like a big way forward, and a big next step is to understand one's risks and putting it in the perspective that we just said, right? It's a way of knowing my cards, or for a policymaker to know the local prevalence, to know the local hotspots, to know the local risks clearly, and then to make what policy they will and weigh the trade-offs carefully. But it feels like having knowledge with minimal risk is really an important thing for me.
Yeah, we should probably have an episode which is just about testing. So we should examine how countries like South Korea and Taiwan did so well because they rapidly, immediately invested in testing. Well, they had pre-existing capacity for testing, and they got everybody tested, and then it's easier for them to quarantine and isolate and treat. And so one of the problems with the British policy is that they eschewed testing initially, and now they're catching up. And to be fair, what they're trying to do is actually mail out home testing kits. Now, as you say, you talked about it as robustness. I would think about it as a reliability problem with home testing kits. That now you're relying on a non-medical person to self-administer a testing kit, so there's going to be more reliability problems at home than in the hospital. But that at-home diagnostic part is preventative in risk management terms. So that would be efficient for the system as a whole. So I think definitely we need to think about how we can decentralize at least the diagnostic part of our management of COVID-19.
Absolutely. That's very well said, Bruce. Well, perhaps we should leave it there as a good, strong takeaway. But
well, anytime we say we should have another episode on X, we should probably leave it there and plot that next episode.
Yeah. Well, we'll be back, and at some point we'll talk about testing. So thank you so much for the great conversation as always, and thank you all for listening.
Yeah, great for having the synergy between your data science on my risk management perspective. I appreciate that.
Yes.
So thank you, Aditya.
Thank you.
We are the Risky Scientists. Goodbye.
Bye-bye.